This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head podcast. Justine Fidelson here with Dr. Dan Bates. Hello,
Hey,
Dan. How are you?
I'm good. 30 minutes. That's what we said we're going to do.
Yeah.
And
who wants to bet? Are we placing bets on that?
Yeah, it's no.
It's an over-under. Well, yeah. We're going to shoot to keep it relatively concise today because we basically want to circle back to a topic that we've introduced as far as central sensitization and neuroinflammation. And if you're not imagining your pain, which the name of this podcast, right, centers around in a lot of what we covered, that poses the question, where is it coming from? And while it's accepted and well acknowledged that central sensitization exists, right, it's a neuroinflammatory process that is amplifying underlying disease processes, where we then struggle is, but what's driving that? And so that's where we kind of hit a dead end at present and in the chronic pain world, where we have a bit of a philosophical issue of if you say that chronic pain has no cause and it's a misinterpretation of a signal, why would you then look any further? And then as far as patients get is a diagnosis of central sensitization. And sorry, there's nothing we can really do about that, or the treatments are lackluster, or at best, we treat the consequences of that process, which are, you know, what I do from a conservative pain perspective. And so we want to kind of introduce that thinking process today and take a look at how we can look at this differently and propose a mindset shift, essentially, where instead of looking at it as a misinterpretation of a signal, how can we explain central sensitization itself from a process perspective a bit better, and what is driving it? And that's what we're going to get into in future episodes in a lot more detail, because once you then understand what various drivers may be to that from an input perspective, you can actually address those and get a lot further than just treating the consequences or at best the process itself. So we're going to get into, like we said, a lot more episodes with specific examples of those various types of drivers, but we want to basically break apart the stages of central sensitization so that you can see the inputs, the drivers, that process itself, the consequences, and what we can use to treat each one of those three rather than just the middle one or the stuff on the very right side of things. So hopefully this episode will help you from a thinking perspective understand that process differently and better understand what is happening in your own body and what's driving that process to begin with.
The other thing that we wanted to do with this is we wanted to link in why lifestyle changes and lifestyle treatment was so important within chronic pain, because what we see is that you go see the doc or whoever and they say you've got pain because you don't do any exercise and you're overweight. So go lose some weight, do some exercise. So, and what we want to do is link all those together, because most of the time that, you know, I think internally for most patients is met with a like, seriously, fuck you.
Right. It's offensive, hurtful.
You live my life. Yeah. You know, you don't know what you're talking about. So let's see if we can link them together in a logical fashion and away we go. So,
yeah, because a lot of those drivers are metabolic in nature, which is where you get that connection between, it's not you're in pain because you're fat, but you're in pain because you have metabolic disease or other things from sedentary lifestyle, right? Dietary changes, et cetera, that are then driving your pain. And so if you can connect that and from a patient perspective, understand why, it creates a different buy-in and helps that communication, you know, issue that we have at present.
So two of the other drivers of today are twofold. One of them was we are preparing like the world's biggest episode on metabolic pain, and we just metabolic drivers of pain, I think is probably better to describe it
specifically.
And we sort of realized that if we just talk about that stuff, no one is listening. Like, I'm not even going to listen. So we want to break those up. This creates a structure in which to think about all those sort of things. And the other thing that sort of triggered this off is I was having dinner with a friend on Monday, and he's a dietitian, super smart, and exists in, like, a lot of his work is in the area of, you know, hypermobile patients, fibromyalgia, chronic fatigue syndrome, you know, pick a central sensitization disorder. that's what he looks after. And we share a number of patients, and we went through in detail like how I'm thinking about this, and he was like, oh, that makes heaps of sense when you add in the what's driving the neuroinflammatory process,
right?
Which I thought, hang on, we share a bunch of patients, we've talked about this heaps before,
Tons.
and it took like 2 hours over dinner for me to explain it,
And
or for
his
me to
background
like,
knowledge
and his
to
background knowledge.
understand it, right?
And I thought, okay, well, that means absolutely no one else
It's
understands
really
what we're
looking at
talking
it.
about.
Is looking at it this way, right? Right. Yeah. So
So
if we couldn't just jump straight into all the metabolic reasons, we wanted to kind of introduce that topic to begin with, the way Dan went through that.
Okay, so central sensitization from a clinical perspective, we can split up into 7 buckets. And so if you've listened to us before, you will have heard this spiel. So central sensitization is sensory hypersensitivity, sleep disturbance, cognitive dysfunction, mood disturbance, dysautonomias, fatigue, and then motor dysfunction. So hypersensitivity includes hypersensitive to pain, and when it's widespread, we label you with things like fibromyalgia. When it's regional, we'll give you diagnoses like temporomandibular joint pain is probably the best example. And then people get hypersensitive to light, sound, smell, touch, taste, heat, cold. They get balance disturbance. You then go on and get sleep disturbance. So you get difficulty getting to sleep, staying asleep, getting back to sleep. You get cognitive dysfunction. So you have difficulty concentrating, you get memory problems, you have difficulty with thinking. And so that sort of gets labeled as brain fog. And in many patients get diagnoses with ADHD. You get mood disturbance. So we label with anxiety, depression. You get your dysautonomias. So abnormalities in sweating. You get lightheadedness and dizziness when you stand up. So we're moving into your POTS diagnosis. You get all your gastrointestinal symptoms. So you get IBS labels. You got bladder symptoms. So you're labeled with bladder pain syndrome. And then you move into fatigue. So your fatigue area is involved. So you got chronic fatigue syndrome. And then you get motor dysfunction. So that's restless leg syndrome, tremors, cramping, myotonic jerk. So that jerking of your arms and legs that comes out of nowhere. And when you're really, really bad, you get non-epileptic seizures. And so, and which get labeled as pseudo seizures, which, anyway, at least that people are just labeling people saying that.
We threw in, inhibition technically under there too, but it's more so, we'll see where that kind of falls.
Yeah. So the question then is like, each one of that presentation of central sensitization is a different area of the brain that is involved. And the thing that is driving that is a neuroinflammatory process.
Right.
And so neuroinflammation is a process where you get what we call polarization of a certain set of cells. So microglia, astrocytes are the glial cells. So what the hell are they? So when you think about a brain or a nervous system, or your entire nervous system, everyone thinks about nerves. And so you're like, okay, we got nerves here, we got nerves there, and they sort of like, you get peripheral nerves, this go into your spinal cord, and they link to some other nerves, and they, there's a complex network that works all the way up to your brain. And you got this, web and mismatch of nerves that interlink. But around those nerves are a set of cells that support their activity. And the cells that support their activity are, I think like it's some stupid number. It's like 30-fold the actual number of neurons that are in the area. And so a number of those cells they're called different names, but there's microglia and astrocytes. And they become what we refer to as polarized. So when we're talking about polarization, we're talking about, are they anti-inflammatory, which are type 2, or are they pro-inflammatory, which are type 1? And so
what direction are they pushing you?
Yeah. And so you can polarize something to be either pro-inflammatory, type 1, or anti-inflammatory, type 2. And the whole neuroinflammatory process is effectively easiest, like it's a ton of stuff, but let's be honest, what it is, it's most easily understood with polarization of these cell types into a pro-inflammatory state. And then they release a whole bunch of inflammatory cytokines. So cytokines are little chemicals that get released from these cells that then sensitize the nerves. And so that sensitization process, it's got a number of different words to it. So the technical pieces are neural plasticity. So if you think about plasticine, like you can push it around and you can move it. And so that's what happens with these nerves. They grow new little endings and new little connections. And so you get plastic changes within the nervous system. And the other way to think about it as well is the technical term is long-term potentiation, which if you just want to say it in one simple word, it's memory. And so you're getting changes in the nerve. So you get new connections and the nerve becomes increasingly sensitive. So you only have to just like touch it a little bit and it fires off by itself.
Right.
And so this doesn't just take place in the spinal cord. It takes place in a little area called the dorsal root ganglion, which is where all the nerve cell bodies are, which is essentially control center of many of the peripheral nerves. It takes place in the nerves themselves, and the whole process just becomes like an ever increasing amplifier. So you get amplification out in your whatever's injured, so the peripheral area, you get amplification in the nerve root, you get amplification in the spinal cord, and you get amplification up in the brain. And these processes tie together this whole concept of neuroinflammation that's then driving effectively memory, and
you get stuck in
and
that
you get
cycle,
stuck in this whole
the
cycle.
ever escalating cycle. Yeah. Right.
And so the question then is, if there's a neuroinflammatory process, what's driving the neuroinflammation? That's the piece. So one of the things that drives the neuroinflammation is persistent injury. Okay, so something that's not diagnosed, that's not completely treated.
Lingers, so like it was never fully addressed.
It's never fully addressed. And so in that setting, what you generally, like how that patient will present is they present dominantly with body part pain. And so it might be disproportionate, but it tends to be really focal. So it's area. Focal, it's disproportionate, but the whole system is wound up, but it's within that area.
It's localized.
Yeah. So in that setting, that's where like guys like me, like that's awesome. Let's go.
Ideally, that's a find and fix.
Yes, that is a find and fix. Let's find this thing. Let's block it. Let's see if we can, and then we can either like take out the nerve supply or we can desensitize the nerve supply, et cetera, et cetera. Awesome. But as things wind up, that's when you start getting central sensitization. And
when that thing wasn't addressed.
Yeah.
Other things maybe are also contributing.
Yeah. Exactly. So then things go from being focal to it spreads. It goes from being intermittent to constant. It goes from being proportional to disproportional. So instead of having little injury, little pain, you get little injury, big pain.
Yeah.
And the other thing that takes place is that instead of specific things that will make something worse, so like you stand up, it gets worse.
Patterns or trends. Yeah. You used to be able to identify.
Everything just makes it sore. So, and so you go from specific things to this, everything makes it sore. And so
or now, you can't find any rhyme or reason anymore. Behind what makes it worse. Yeah.
And so that's when you then start having this amplification thing. And then you've got your 7 buckets of sensitization taking place. And what's happening, it's a neuroinflammatory process in specific areas or systems within the brain. So when the fatigue system's involved, you get fatigue.
Right.
When your cognitive systems, your ability, like that drive your thinking, when they're involved, that's when you get cognitive dysfunction.
Yeah, so different area of nervous system, different symptom bucket.
Yeah. And when your visual system's involved, what do you get? You get hypersensitive to light. Like that, it's not that hard to sort of work through. And it's interesting. There's been some papers recently, particularly around long COVID, that are starting to look at and go, hey, here's the anatomy of the brainstem. All these things are associated, all these things that control sweating, fatigue, like my heart rate and blood pressure, gastrointestinal, they all exist within this little area. Maybe this is a neuroinflammatory process in this area of the brain. I think it's pretty much accepted that long COVID is a neuroinflammatory process. But the anatomical piece is like, well, maybe it's here. And
if you can get more specific, you can treat it more effectively.
Exactly. Yeah. So that brings us to, we've got a neuroinflammatory process that's amplifying everything. What's driving the neuroinflammation? Central sensitization is being driven by a neuroinflammatory process. So what we did is we sat down and we went through all the central sensitization disorders. These are things like fibromyalgia, chronic fatigue syndrome, temporal mandibular joint pain syndrome, et cetera, how to look at what are the most common conditions associated with those diseases, and then looked at what the most common were within that. And so what you find is that, not surprisingly, inflammatory disorders, so rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, et cetera, are most associated with these central sensitization disorders. You've then got diabetes, hypothyroidism. Interestingly, celiac disease comes high in the list. The next thing is then hypermobility, which opens up a whole other world into other conditions, such as what's the role of MCAS in that setting? What's the role of POTS in that setting? How are they driving this how are they a cause plus a driving this process?
And we'll pull that out in other
tease
episodes.
That out. Yeah. And the last piece is then obesity, which is interesting in itself, about how that links into all our other issues, which is then, cardiovascular disease and hypertension.
Right, everything under that umbrella, that
hypercholesterolemia and blah, 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 and how they all link together.
So basically, if you're not imagining your pain, again, this brings us back to, where is it coming from? And just treating the consequences is not enough. You can't just mindset and meditate your way out of this, although that can be an important piece of things. It's not going to cut it once you're highly wound up and highly sensitized. It's also fair to assume that in complex long-term patients with a lot of overlapping conditions and widespread pain, you're not going to necessarily be able to find a more specific cause or driver, like we talked about from an injury perspective, to that pain. That is not where then you insert, there's no cause, misinterpretation of a signal, and why would you look any further, which is the issue that we currently have. So what Dan just went through instead allows you to have a set of things that you can look at and go, oh gosh, could those things, could 1, could 3, could 5, right? How many of those things actually, or even a different disease process like we covered, such as hypermobility, be driving that neuroinflammation, which is then giving you the output of symptoms of those 7 buckets, which I can treat to a degree with conservative interventions. And those things also validate why those lifestyle interventions are so crucial, because if you're overweight and sedentary, lack, muscle mass, can't take care of yourself from a nutritional perspective, now you're hurting yourself from both ends, the inputs and the outputs. So we want to and have to treat the consequences. I would consider those basically like the non-negotiables. But even I have to admit that those things have a certain ceiling if you never try or never identify all these things on the left that Dan just went over, which in the current pain space, we don't, because we say it's a misinterpretation of a signal, and this is where it's in the patient's head, harm, et cetera, gets created, instead of having a thinking tool and a way to actually sort through this and systematically go through.
Yeah, great. And so for me, the best example of chronic pain, in part a metabolic disorder, is prediabetes. All right. Prediabetes, we also refer to it as insulin resistance. What we are doing when you have diabetes, particularly type 2 diabetes, put type 1 there, it's a completely different disease, but type 2 diabetes is your glucose is going up because you're not unable to bring your glucose back down and control it. And the way you control your glucose levels is with a hormone called insulin. Now, over time, our body becomes more resistant to insulin for multiple reasons. And we'll dive into that at some other point in time. Juz will tell me off again for talking too much if I talk about that. So
stay on target.
She told me off before. Dad, too much monologue.
Monologue mode. I just go MM. But what's so funny is me individually, I could get into monologue mode and Dan can get so it's okay.
Okay, back on it. Okay,
all right.
So So pre-diabetes, the way your body responds is that as you become more insulin resistant, your body pushes the amount of insulin up to make your cells respond, and so keep your glucose under control. So because high glucose levels is bad for us. However, what ends up happening is that the high insulin levels also drive a neuroinflammatory process. And so if we take the hypothesis that pre-diabetes is associated with more pain, then you should be able to see this in the literature, and it's there. So there's been a great study that looked at a bunch of patients that had pre-diabetes, and they show that they are far more likely to have neuropathic pain than those people who do not have pre-diabetic state.
Right.
And so, like, from an epidemiological perspective, you can see that as a process. What I see in the rooms, and this is where I started to really see this, is that I'd have a patient that would come in, one of the earliest patients, this is how patients present. They come in, they are overweight and generally significantly overweight. And for many patients, I can have that conversation. I've got better at asking people about, okay, what have you done for your weight before? Because everybody's done something for their weight.
Right. They try different things.
They've always tried. And they go, I don't eat anything, but I keep on putting on weight.
But over fat.
So what's happening? So the patient that says, look, I can't lose weight. I don't lose anything.
I'm barely eating anyway.
And I've got pain. And interestingly, I had a couple of patients come in with just weird neuropathy, just strange distribution neuropathic pain. And I was like, okay, insulin's a storage hormone. If basically what's taking place is that if your insulin is really high, what takes place is that you eat something and you just store it all. Like we don't live, you essentially don't live, like you don't live off the food that you eat,
You live off what you store.
Yes, you live off what you store.
And your body learns it's not getting more, especially if it's hard for you to eat because of nausea, side effects, lack of appetite, no hunger cues, right? And so it creates this hold, even though you're eating practically less and less and less.
Ooh, I like that. I hadn't thought about it that way before. Yeah.
Yeah. Well, and then this is from a body comp perspective, right? Yeah. Wasting happens, and it's very perplexing for patients too.
Yeah. So when I first started investigating this, I had a patient that I set him off to get what is called an oral glucose tolerance test, which is a really annoying test where we give people 75 grams of essentially goopy, cola, and you test what happens for their glucose over 2 hours. And I also asked for what's called an insulin curve. So I want to know what happens with their insulin over that period of time, as well as what happens with their glucose. Because if that entire system is doing its job properly, then your glucose should stay within normal ranges.
You shouldn't get a crazy spike.
You shouldn't. So for this first patient, I sent him off. I said, dude, can you get this as well? And the pathology company didn't do my insulin curve. So they didn't do it. And so he had a normal long-term glucose. He had a normal fasting glucose, and his glucose curve in the glucose tolerance test in the oral glucose was normal. And I was like, there is no way this is normal.
Right.
And so I went, dude, can you please go back again? And I wrote in capital letters on the request, do the insulin curve, please. Yeah. And so they do, and he comes back and his insulin's off the chart. Everything else is normal. His insulin's through the roof. And so since then, I've started to see, more and more patients that present with kind of weird neuropathic pain in the setting of weight gain, normal glucose levels, and HbA1c. So the doctor keeps on saying, oh, you're good. You don't have diabetes.
Right. There's nothing wrong with you.
Nothing's wrong. But their insulin is 300, with, at least in this test that we're doing, normal range is effectively 30 to 160. And so if you're at 300, I got to tell you that produces weird neuropathic pain in many people. Now, for those people that are lower though, let's say that you're just above. So you're a bit hyperinsulinemic. So your
Not
insulin's
crazy.
a little bit high, but it's not crazy. I think what you see there is that it just adds to, it's just a
It's just
little
making
bit
it
of an
worse.
amplifier. It just makes it
Yeah.
worse.
Right.
And you've got other things that you start to get this stack. So your insulin's a bit out. There's good data that shows that if vitamin D is a bit low, it also will amplify pain. And it does it through inflammatory mechanisms.
3% here, 3% here.
Yeah.
3% here.
Exactly. And omega-3s, interestingly, are the same. And like if they're a bit low, they act as an amplifier. And I think that, but each one of these metabolic drivers, if they are at their extreme ends, insulin over 300 on these guys' test at any rate, that's a driver by itself. Yeah.
Right.
Looking at my experience with vitamin D, if it's in like just under 30, sure, it's a little bit of an amplifier. Does it make that much difference? Probably not. If it's under 10, it produces weird pain. Like just that doesn't make sense. And omega-3 is the same. If you look at an omega-3 index, if it's really low, produces weird pain. And but if it's omega-3 index, when I do them at the lab, now they do them for me. In this lab's normal range, their normal range is 8 to 13%. I would say 99% of chronic pain patients, it's in this 4 to 5% range. And once it's under 2%, that seems to produce weird pain of its own special sort.
Yeah.
So, but that's purely observational. Although there is some good data that shows that low omega-3 index is associated with chronic pain. That's the reason why we test it. So,
right. You can see how each of these individually, that's one thing. But when you add a bunch of them together or a few of them that are way out, and that's for me too, working with super complex patients, long-term chronic illness, sedentary lifestyle, all the nutrition stuff off. Why do lifestyle interventions or doing the things that for a lot of these things that Dan mentioned would be the appropriate thing to do have such a disproportionate impact? That's why, because you're addressing some of the, not just the amplifiers, but in that patient set, some of the drivers too.
Yeah. And so, and that's great. Such a great lead in. And so that is like so many people have come to see me over the years and they go, yeah, my doctor's told me to do some exercise and lose some weight. All right. So let's link that to hyperinsulinemia. So
because it's not as simple as you're in pain because you're fat.
Yes. No, it's not. You're fat. You've got pain.
Actually,
That's not what it is.
No.
What it is, and what it is for many people, not all people, but for many people, is that you become insulin resistant. It's a pre-diabetic state that results in people putting on weight. They can't lose the weight.
Right.
The recommended treatment for pre-diabetes is exercise and weight loss and, fix and sort your diet out. So the link there is the insulin. Your insulin is high. It drives a neuroinflammatory process. The neuroinflammatory process sensitizes these nerves. This causes pain hypersensitivity. And when it affects the pain system, you get widespread pain and you get disproportionate pain. And so,
and then you get the buckets. That's where then you get,
so then what you get is you get the doctor saying you need to lose some weight and do some exercise.
Right. Total disconnect.
They're not connected. It is the right treatment.
And also there's no pain signal. So it's
and there's nothing.
Right.
No.
So it doesn't matter, but it matters, but it's your fault also, right? And again, you end up in that position, unfortunately, because of a lot of the consequences of being in pain or the side effects of treatments. And so from a buy-in, from a behavior change perspective, you have to understand the why to care and to see that, oh, wait, not only do I care now, but I see why I would do that. Because whenever I'm trying to explain something to someone, I always come from the perspective of like, but why would they give a shit? And that's what you have to get people to see. And that's what looking at it in this way, rather than a misinterpretation of a signal, that's why it's so powerful.
Yeah. Many years ago, particularly when I was doing more osteoarthritis management, that everyone would come in with, you've got to, do some exercise and lose some weight. Okay. And so, however, everyone starts with, yeah, but my knee hurts. Right. And so I would just shift that. Okay, let's get your pain under control. Then we've got to do some exercise, and we've got to lose some weight because basically the way it works is that, Dan, I used to be really fit. Yeah. I fell over, hurt my knee. I couldn't do any exercise. I ended up putting on weight, and
vicious cycle.
And my pain got worse. Okay. Yeah. And so what you then need to do is that, okay, let's see if we can get on top of your pain. And the other important thing is that I can't do any exercise because my knee hurts, and I can't lose any weight because I can't do any exercise.
Well, right. And or the barriers of anxiety, depression, also these other barriers to,
So what you got to do is I shifted to, okay, let's get your pain under control. Then we'll get you doing some exercise. Then we'll get you losing some weight.
Which will also help your pain then.
Which then helps your pain.
Right.
And so,
but it's not exercise first when you have all the barriers
but bring it back to the hyperinsulinemia piece. This is why lifestyle changes links to chronic pain, because it's these metabolic changes that take place. And hyperinsulinemia is just one of them,
Right. So that's the one example we pulled out for this episode, basically.
One. And then there's the vitamin D, your omega-3s, your homocysteines, your blah, blah, blah. Smoking. Oh my God. There'll be a bunch of people that don't like that conversation, but absolutely smoking introduces a bunch of chemicals that sensitize your nervous system.
Well, and even the lifestyle stuff is hard sometimes as a patient to hear, but I'd rather as a patient feel like, hard as it is and challenging as it is to take ownership over this gives me agency, right? This gives me something I can impact instead of, you're crazy, it's in your head, bye, good luck, and there's no solution. So it's difficult, but this type of shift in thinking can help you actually get out of the hole that you're in instead of just feeling hopeless, which is a terrible place to be.
So with the treatment now, we've gone from there's no cause and it's a misinterpretation of a signal, and so now we've got central sensitization with 7 buckets with a set of outcomes. And we know that those outcomes make the neuroinflammation worse. So the easiest one to understand there is sleep. Neuroinflammatory process, sleep disturbance. Sleep disturbance makes the pain worse. And so you've got to deal with the negative sleep outcomes.
Right.
Okay.
Right.
And similarly, you can look at that from, your POT symptoms. Your POT symptoms, you're continuously dropping your blood pressure. That causes blood flow issues to your brain. That drives the neuron. So you've got to treat the outcomes.
Right. Right.
We've also then gone through, okay, now you've got other metabolic drivers on the other side of this that are then driving the neuroinflammation itself.
Yeah, you've got left side, right side. Neuroinflammation in the middle.
Yeah. And then you've got the neuroinflammatory process. And this then creates your next target you can start thinking about to treat this. Now, at this point in time, this is the least investigated target and least thought about target. But thank you to COVID, people are sort of now starting to look at it as a treatment option. And so the long COVID data is really interesting. And there's things like palmitoyl ethanolamide, luteolin, that particularly the Italians have done a lot of studies on that is directly treating that neuroinflammatory process. There's also the other experience most people have had within the chronic pain world is LDN, so low dose naltrexone. What that is doing is that is treating microglial polarization. So taking it from type 1, which are pro-inflammatory, to type 2, which are anti-inflammatory. And there's some other studies around magnesium, particularly magnesium L-threonate, where people are specifically researching around the neuroinflammatory process.
Right.
And so what we've then gone from is, okay, there's no cause. And then there's guys like me that can go and find a cause. Then you've got, what are your metabolic drivers? Okay, we can do a set of investigations to look for those metabolic drivers and then treat them. And I've got to tell you, if you group into that top 10, I find stuff a lot. 3, can you treat the neuroinflammatory process as well? And that's really where LDN comes in. And you look at particularly the fibromyalgia data, and you look at the chronic fatigue data at the moment. LDN is becoming increasingly efficacious within that setting. And then you treat the consequences, which is where we're all at the moment. Oh, I can't
Right.
do anything for you. We'll just treat the
At
7
least
buckets.
we'll do that. Right.
Yeah.
But you're still stuck in a bunch of positive feedback loops if you never
Yeah.
look at the drivers. And granted, some of those lifestyle interventions, again, will influence some of those. But if they're not truly identified, you don't have a structure to think about this whole process more broadly. Instead of just neuroinflammation, you're screwed.
Yeah. And that's such, like, that thought process is a long way away from you've got fibro, get the F out. Like,
right.
that's
right.
it. Or, and in some way you're centrally sensitized, get out.
Right. It's just an alternative because there isn't a way to think through it. At best, it's treat the consequences. And that part, the medical system struggles with because of limitations of the system like we talked about, or pain programs don't communicate or apply, the education in a way that is particularly helpful for this group.
They're sitting within the philosophical construct that there's no cause and it's a misinterpretation of a signal.
Right. So why would you look again?
So why bother looking?
Anything else? Yeah. Right.
So there you go. Maybe not 30 minutes, but we got there.
Yeah, that was pretty good. Even with the monologue. I love that I could finally tell you. It's happening, Dan. It's happening. It's okay. It's okay because you're just real passionate about this stuff. Right. I can't help it.
Let's wrap it up there because you'll make me monologue again. And
no. The end point is we recognize, right, the complexity of this process. Obviously, even this episode, as simple as we tried to make it, is relatively complicated. But blame the patient plus treat the consequences is not good enough. Neuroinflammation is amplified by those consequences, yes, but there are inputs and there are drivers that if you identify and you change the way that you look at it, again, I guess from a philosophical perspective, it gives you way more to work with. And then you can see the 3 parts of pain, not to be confused with the 3 types of pain, right? The parts, the inputs, drivers, neuroinflammation, and then the buckets that are developing the consequences of that nervous system dysfunction. So hopefully this helps you see why lifestyle habits, again, really do impact pain, particularly if you're in that weird symptoms, widespread, everything makes it worse. And of course, my fitness has suffered after 15 years of living like this and being on a million meds. So how you can slowly undo that ball of yarn is hard, but it's possible. And it's a lot better from a patient perspective than you're crazy. It's in your head.
Yeah.
Good luck.
It's not in your head.
Nope.
All right.
Perfect. And so, in future episodes, that's what we'll basically dive into is we'll pull out a lot of each of these individual drivers that Dan mentioned and help you understand how every one of those from a process and then an intervention perspective can impact things.
Yes, we will. Brain weights.
All right. Brain weights. Yeah.
All right. We'll talk about that later. All right. Let's go.
We'll talk about brain weights later. All right. Okay. We will see you guys next time on It's Not In Your Head podcast.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.